Good morning, everybody. I'm going to outline for you what we're going to do today, but before that, I just wanted to start out and introduce this topic a little bit. You'll notice that sometimes we use the words non-government and private interchangeably, and let me just give you a little background on that. When we first started talking about the private sector, we got feedback from NGOs and CSOs that they did not like to be called private. So in their minds, they are more of a government-related type agency. So long story short, you'll probably hear me use those terms non-government and private interchangeably. When we do say non-government, we do include both for-profit, private facilities and providers, as well as those not-for-profit, such as NGOs and CSOs. So just to be clear, when I'm talking about private, I do mean both. And when we, I'll distinguish between the two as we go through that. But just wanted to explain why that differentiation. So here are the objectives for this session. First, our goal is to describe the considerations relative to using non-government providers for delivery of immunization services. The goal is also for you to learn from other countries in the region about their experiences with non-government providers, and then to identify strategies to engage or to better engage with private non-government providers relative to service delivery, relative to data quality, relative to AEFI and vaccine preventable disease surveillance, and relative to advocacy and communication about immunization. So here's the outline. Here's what we're going to do this morning. I will give a short background presentation, review some of the literature on this topic, which is relatively little, scant literature, but we'll review in the literature what is known about the considerations relative to non-government providers. And this is relative to their contribution to coverage, service quality issues, recording and reporting issues, regulation, and engagement and their role in decision-making processes. Well, also, many of you participated, thank you very much, in a short survey that we sent out in advance. Just an informal survey about your countries. So I'll summarize that information. Then we have two countries who have graciously agreed to present this morning, Sudan and Lebanon, on their experiences in short presentations. We will then take a break, and then when you return from the break, we're going to have a group exercise. We're calling it a 6-station walkabout. It's kind of similar to a World Cafe, if any of you have done that before. We're basically going to use the 6 recommendations that WHO has just come out with relative to this topic, and there's going to be 6 stations with flip charts around the room. And your countries will travel from station to station. So you'll be up, you'll be walking around. Every 10 minutes, you go to a new station. So I'll introduce that more right after break. I'll explain in a little more detail. But you'll be walking around. That exercise will last probably about an hour, 10 minutes at each of the 6 sessions. And then there'll be a facilitator at each of those stations. And then after this walkabout, those facilitators will summarize some of the key points that came out of those station sessions. So that's the plan for this morning. So first of all, I'm just going to give a little background about this topic. I'll start out with a brief review of the literature, and then we'll talk about these considerations that I mentioned earlier. We'll do the snapshot, and then I'll mention those 6 new recommendations that came out that you'll become more and more familiar with. So, what do we know about this topic of non-government providers? Well, one thing we know is that there's not a whole lot out there in the literature We looked a lot in that. We found out that there have been 2 reviews of the literature. One of them is not published yet, the one by Mitrovic, but there was one published in 2011. And basically, to summarize both of those reviews, they said basically there's not a whole lot of literature out there, so if any of you want to write up your experiences, they would be, I think, welcome, because there's a gap in knowledge about this. They determined that the private sector takes on a variety of roles in countries. It really varies. It's very country specific, and that's understandable. The contribution that private sector makes to the coverage is very poorly documented. We'll review some of those studies, but it's not well documented. When we talk about nonprofit sector, NGOs and CSOs, for example, the literature found that those NGOs really, they extend the delivery of EPI vaccines, and I think many of you would agree with this based on your experience, especially in fragile and low-income countries. And those non-governmental organizations, they tend to be more coordinated with the public sector than the for-profit sector does. There's concerns about the quality of the vaccination services delivered, and there's not a whole lot of monitoring that goes on relative to that. And there's not much information about regulation of the private sector, about interaction with pharmaceutical companies, or there's few examples of really good examples of public-private collaboration. So let's talk about first this contribution to coverage. What is the private sector contribution to coverage? And there's really, once you start looking at it, there's 3 dimensions that you can look at for this. You can look at, okay, what proportion of private providers give vaccinations? You can also look at, of all the vaccinations given, what proportion are given by the private sector? Or you can, in some countries, you can compare the coverage that's given of vaccination given in the private sector compared to in the public sector. So we're going to go through and summarize each of those. So first, starting with what proportion of private providers give vaccine? There was a study done recently in 4 African countries using secondary data, using service provision assessment data, which is collected by DHS. And it found that vaccination is provided less often in the private sector than it is in the public sector, or the for-profit sector actually gave the lowest proportion of vaccines. So in this 4 African country study, the range was by country, 25 to 37% of private providers gave child vaccine. The not-for-profit, a larger proportion did give vaccine, and of course public, the vast majority of public facilities gave vaccine. The proportion really varies depending by antigen. For example, in a Cambodia study, 36% of the for-profit providers offered hepatitis B vaccine, but only 4% of those same providers offered measles or DPT. So it really varies depending on the vaccine. So then the second way of looking at it is, of all the vaccinations provided in a country, for example, what proportion are given by the private sector? And again, this really varies by antigen and by country. So, for example, in Spain, there was a study that found that private providers gave 31% of all EPI vaccines, but they gave a larger percent of varicella and PCV vaccines, which is understandable. These are the newer vaccines. They're not always given in the government sector, so that makes sense. And also that this proportion really varies by country, it varies by region, and it varies by whether you call partially vaccinated or totally vaccinated. So here, this is an example, and this happens to be data from India, but it's replicated in many other countries. And what I just want to point out to you, on the left are all the different parts of the country, and so you can ignore that for now, but just to say that there's huge variation within countries. And what this variation boils down to is, if you look on the right, in India, for example, this is 2009, about 20% of all vaccines were given in the private sector. But that really varies depending on two main things. One is rural or urban status, and you can see that in urban settings, it's much higher. It's 22%. I'm sorry, I meant overall 9% of all vaccines are given in India. Sorry, I said that wrong. Overall, 9% of all vaccines are given in the private sector. However, in urban areas, that's 22%. And I think that makes sense, right? Most private providers, especially for-profit, are found in the urban settings. Rural settings, it's much less common. Also, and this is no surprise to any of us here, I'm sure, the wealthiest quintile, or the wealthiest population, has the highest proportion of vaccines given in the private sector. So I think that's probably not a surprise to any of us. And like I say, that has been replicated elsewhere. Now, this is data, and I've circled the Eastern Mediterranean countries that did report on the JRF. There's a question on the JRF that asks what proportion of vaccines are given in the private sector in your country. Now, you have to take this data with a grain of salt, because what we learned was that countries define private sector in different ways. So take this with a grain of salt, but basically the take-home point here is that there's a wide range by country of the proportion of vaccines that are given in the private sector. And this is an estimate. This is asking the EPI managers, and many of you probably saw this question: what proportion of vaccines in your country are given in the private sector? So again, take this with a grain of salt. Take-home message here is that there's wide variation, and that and it varies by region also. So Euro and WIPRO, there are more countries that have larger proportion of vaccines given in the private sector. All right, so now the third way of looking at coverage is how does coverage compare within a country if you look at private coverage versus public coverage? Not many studies out there looking at this. There was a study in sub-Saharan Africa that found that the odds of not being vaccinated were 5 times higher in areas where all the facilities were for-profit compared to areas that had no for-profit. It was somewhat of an ecological analysis, but basically they found that not vaccinated was associated with being in the private sector. Other studies in Vietnam and Philippines found lower hepatitis B birth dose coverage in the private sector compared to the public sector. Spain, though, the study in Spain found no difference between the coverage public versus private. And then a study in Gabon found that for-profit coverage was higher than in the public. So you're all over the map here. Some studies say coverage is higher in the public sector. Other studies say it's the same. Other studies say it's higher in the private sector. So basically, it really varies a lot, and I don't think we can generalize. So that's the coverage issue, and it's not definitive because there's not that many studies out there, and they're all done in different ways, and the findings are different. So now let's turn to service quality. We've talked about coverage, but what about quality of services? Are there problems in the private sector? A study in Cambodia found that the private sector workers lacked knowledge about vaccine schedules and vaccine management. A study in Mauritania and Malaysia found that the private sector lacked correct cold chain equipment. A knowledge, attitudes, and practice study of private pediatricians in urban sections of Gujarat state, India, found that 60% of the private pediatricians giving vaccine were not using AD syringes. And cold chain, we found that there were stage 3 to 4 VVMs in 18% of the observed refrigerators. And this is actually a study that we did last year in India. And then the vaccine vials were sometimes stored in unrefrigerated thermal boxes, and most of them were stored in domestic refrigerators. Now, also, there were missed opportunities. The same study in Gujarat, India, found that 60% of the private providers said that they would not give more than 2 injections per visit. Half of them would not vaccinate a child if they did not have a vaccination card, and half of them would not vaccinate a child with a mild illness. The study in 4 African countries relative to missed opportunities also found that less than a third of private providers assessed vaccination status during a curative visit. Now, obviously, this is not ideal. There are some quality issues. We know that we also have quality issues in the public sector, right? So there's very few studies that do a head-to-head comparison between private and public within a country. So we know that we would find challenges if we did, the very same study in a public sector. But still, there is evidence to say that there's room for improvement relative to service quality issues. Okay, what about reporting and recording? Here are just some examples from the literature. The reporting of doses by private providers. Very few providers in that study in India used a vaccine register to record doses. In a different study in India, there was really sporadic reporting to the government of hepatitis B vaccine, but it was more consistent in states that had a mechanism for reporting, which is not a surprise, right? In states that had a good system set up, a reporting system, good system set up between the private and the public sector, the reporting was better. So it's, not surprising. That's kind of a no-brainer. In Philippines, there was a study of looking at hepatitis B birth doses, and 36% of the private hospitals reported, only 36%, whereas 96% of the government clinics reported. So reporting is not optimal. What about AEFI and vaccine preventable disease reporting? Well, in the study in India, many providers said that they would not report AEFI or measles or polio or other vaccine preventable diseases. 64% said they'd report an AFP case, but when we asked them, well, would you report a case that came in with fever, rash, fever, and cough, only 22% said that they would report that case. We didn't call it measles per se because the case definition, we wanted to stick with the case definition. But most importantly, most of them were not aware that they were supposed to report. So that's, one of the key problems. All right, then moving on to regulation. What about regulation? There's very little literature on this topic. Most lower and middle income countries, what the review of the literature found was most of them lacked the mechanisms to adequately reinforce or enforce and regulate the standards, and mostly it was due to limited human and financial resources. Most high-income countries did have mechanisms in place. Wipro did a survey last year of 14 countries, and they found that 12 of the 14 countries had a system in place for regulation, but only half of the private providers were aware of that there were policies and laws and regulations. And then 11 of those 14 countries did regulate service fees by private providers. All right, and what about the extent to which private providers are engaged in decision-making processes? Well, one conclusion is that not-for-profit facilities are much more likely than for-profit facilities to have arrangements in place, whether it's an MOU or a contract with the public sector. That Wipro survey that I mentioned found that there was a very low level of private provider involvement in decision-making. So this is things like developing guidelines or sitting on the NITAG. So there's definitely room for improvement there. So this is kind of a summary slide about what are the risks, benefits, and challenges of engaging or not engaging with the private sector. So what's the downside of not engaging with the private sector? Well, one thing is you're going to have limited knowledge about your true state of population immunity. If you don't know what contribution to coverage the private sector is doing, you really are limited in what you know about immunity gaps. And you also might not know that there's practices going on that contribute to suboptimal immunization, whether it's cold chain problems, for example. And then there's disparities among populations. So if you know who is being vaccinated by the private sector, that's important to know that if they're only vaccinating the wealthy quintile, for example, that's good information to know. And then there's also, if you don't know what the status is, you can't really improve it, right? So there's this inability to improve or to enforce service quality issues, especially because there's very little monitoring that goes on in most countries about what happens in the private sector. So what are the benefits of engaging with the private sector? Well, there is some potential for expanded reach to populations that aren't being reached other ways. For example, in the urban setting, there are some countries that actually sometimes utilize the private sector clinics to reach urban setting populations. And Ghana, for example, is one example that actually the government actually uses the private provider offices for their vaccination services. And then there's also the potential to maximize efficiency if there's good coordination in the service delivery between the private and the public through collaboration. But it's not easy, is it? What are the challenges to engaging with the private sector? So there's often this lack of trust between the public and the private sector. The private sector is concerned about excessive regulation. They don't want to have a lot of controls on them, and they may trust, or they may think that the public sector is not as efficient as they are. We've heard that. And vice versa. There's obviously, in the government sector, sometimes there's a lack of trust and suspicion about what's going on in the private sector, and is it all for profit? And so there's this lack of trust that is a challenge. There's really no established platform to convene stakeholders about these issues and the roles and responsibilities. NITAGs may be an option here, but not all countries have NITAGs. Not all NITAGs have private providers sitting on them. It's not one size fits all. Every country is different. Every country has to address their own issues. And there's very little information out there about successful collaborations. So if in your countries you've developed a successful collaboration model, encourage you to write it up and spread the word about that. So in conclusion from the literature, Number one, there's not a whole lot of literature out there. Number two, the contribution to coverage really varies, but we do know it's higher in the urban setting and it's higher in the wealthy portion of the population. We know that for-profits provide less immunization than not-for-profit or public. We know that there's service quality issues, but they're not systematically collected and documented. We know that there's suboptimal reporting and recording of doses and AEFI and disease reporting. We know that there's lacking adequate regulatory and accreditation framework, and we know that there's a low level of involvement in decision-making and NITAG involvement. So, several of you participated in that survey that I mentioned, this informal survey, and just to say, you will get this, but I did compile all the results from each country that responded, and you'll note that on the bottom, Iraq and Libya, they did respond, but in those two countries, private providers are not vaccinating. So thank you for responding. Rather than going through this in great detail, So 7 countries responded. 2 of those countries, the government, non-government, are not involved in vaccine delivery. About half of the countries that had non-government providers had a database for non-government providers. We asked the question, do they report doses consistently? And about half of you countries said yes, but it really varies by facility, and it may just be NGOs that are reporting, and mostly it's paper reporting, not so much electronic registry reporting. The proportion of doses given in the non-government sector ranged from about 3 to 50%. 4 of the 5 countries provided training to non-government, and as far as reporting AEFI in vaccine preventable diseases, do they report them well, was the question. 3 of the 5 countries said, yeah, they report, but there's problems. And then we asked the question, generally on a scale to 1 to 10, how satisfied are you with the performance of non-government providers? The mean was 4.75. The range was 1 to 7. So there's not 100% satisfaction with the current status. Then we asked, what are the challenges? And this is just a summary of some of the challenges. You all reported that the vaccines aren't free, that they charge fees, so that's an equity issue, that the staff is lacking in skills, that there's concerns with new vaccine introduction, that there's government funding issues. So sometimes the government, when in situations where the government funds the private not-for-profit sector, sometimes the funds get withdrawn, and then that leads to no services. So that's an issue. There's defaulter tracking issues. There's rumors that are sometimes spread in the private sector about EPI, and there's service quality and scheduling issues. So that's what you all reported back to us. Okay, so just to finish up here, so I've given a background on that, and I'd like to say that in April of this year, there was a SAGE session on this issue, and what came out of that is that basically the main summary is there's really no universal standard approach to engaging the nonprofit sector, or excuse me, the non-government providers, because countries are so variable, the situation is so different country to country, so there's not the one standard way of doing this. But there is an overall recommendation, and I've put it here. It says national immunization programs should optimize collaboration and communication with non-government providers. Then there are 6 specific recommendations. They are listed here. You will become more familiar with those because at each of these six stations after the break, every station will be one of these recommendations. And then there's some sub-bullets within each of those recommendations. And so what we're going to ask you to do is to either describe what your country does relative to this, or what your country could do to stimulate ideas about how you might increase and improve collaboration with the private sector. I'll just review them very quickly. One is to first do an assessment. What's going on in your country? Doesn't have to be a formal assessment, but look at your existing data, look at the stakeholders, talk to them, et cetera. Number two is determine what is the optimal model for my country relative to private providers. Maybe it's not, but at least you should think about maybe non-government providers don't provide any vaccines. Maybe you want to consider that they could, or maybe you want to consider that they could be considered advocates. You want to facilitate dialogue and establish agreements and contracts with the non-government sector. Number four, you want to ensure good data management and reporting. Number five, adequate training and capacity building. And number six, facilitate accountability and performance oversight. So that is the end of my background presentation. Now I'm going to have the two countries that very graciously volunteered to present come up and just describe in short presentations the situation in their country. And I think we'll start with Sudan. And Dr. Ishmael, you want to come up, and I'll pull up your presentation.
We are here from Sudan to share with you our experience in the private sectors in Sudan. So our presentation is talk about the type of private sectors, key steps, private sector contribution to immunization, strengthening and challenges, and futures plan. If we talk about routine immunization, we talk about accessibility and utilization for routine immunization. So the accessibility, it is a responsibility of the health system. So we can talk about the health system or the routine immunization. It is a part of the health system. Also, when we talk about utilization, utilization for the vaccines and immunization services, and this is referred to demand of the community, and it is the part of our activities there. So the health system, it is have a responsibility to deliver these services for all eligible children. And this is talk about the health system. When we talk about the government, the situation analysis for the health units or health mapping, the government cannot cover all the area with the services. So we need some solution from other part. This is called the private sectors. We need the private sectors to, as a part of solution for current challenges. We have a type of private sector in Sudan, for profit and for non-profit. For profit, generally, in the population in urban areas, like big city in Khartoum state or Jazeera state. For non-profit, mainly refugees and IDPs come. This presence in Darfur states or Darfur zone and Kordofan zone, and also White Nile after the separation between Sudan and South Sudan, and you know about the returnees. The authority body for all these private sectors We have body for each one. It is a profit or non-profit. So we have key steps for working in immunization in these groups. Either it is public or private. The same, they work all private providers regulated by national bodies, while technically they follow the EPI rules or policies. When we want to plan for immunization services, first we have key activities done in the EPI program. First of all, mapping of the location of unreached children or partially reached. This is the mandate of EPI planning. Mapping of the active partners. When we want to talk about the utilization and increasing demand of the community, we have to look for some partners to share this responsibility with the government or share with the EPI program. Immunization planning, implementation, and monitoring. Also, we follow these EPI guidelines and policies in the public or private as well. That means we deal with the private sector as one unit or health units, just like the public health unit. When we talk about the guidelines, EPI guidelines, we talk from the planning, implementation, and monitoring evaluation. Those are private sector's units deliver these immunization services. We follow by supervision and evaluation for these units. The contribution, we have some example of certain state for the private sectors. In Khartoum state, 47% population covered by private sectors. 37% of Darfur population is covered by NGOs, national and international, and 10% in Kordofan or West Kordofan. The coverage, also the contribution of the private sector, 52% children received 3 doses of a pentavalent vaccine in Khartoum, 31 in West Darfur, 90% in West Kordofan state. Also, private sector contribute in the surveillance system, as well as routine immunization services. And here we have the AFB cases from the private sectors. That means all the private sectors units share with us the all surveillance disease or EBI surveillance disease, either AFB or measles or other diseases or adverse event following immunization. Also, the private sector participating in many forums of us, National Immunization Technical Advisor Group or Immunization Community Committee or others working group at the national level or at the state level. Even at the district level, we have some share with the private sector. That means they will share with us or contribute it with us in the planning or implementation or evaluation or replanning again for the immunization. And here have some challenges, strengths and challenges. The strengths, improving access to immunization services because the private sector cover all areas that not covered by the government. So they help us a lot, and they are part of the health system. National existence of the national and state regulation that regulate action of private sector. All the health units, either it is public or private, follow our regulation and policies. This is a strengthening. When we face some challenges, national summary of existing private sectors coverage, we can solve this in the coming days, inshallah. Service sustainability due to evacuation of the NGOs in Darfur zone or Kordofan zone sometimes, and handing also. No enough coordination and information exchange between EPI and other public. We have here some other public health units. They based or the part on the health system, but we can call it as other public health centers. Here, the future plan strengthening the national EPI information system on analysis of private sector coverage, strengthening the coordination and information sharing between public and non-public governmental sector, joint revision of private health facility regulation with EPI, addressing private sector non-service providing to financially invest in immunization. Thank you.
Well, good morning. I'll be talking to you about the EPI program and the collaboration between the private and the public sector in Lebanon. First, to set the stage for the situation in Lebanon, as many of you might know, we have a unique healthcare system where there is a very strong private sector, and we have also a public sector that provides the EPI services in Lebanon. So as a background for us, what we consider as the public center, sector, are the dispensaries and the primary healthcare centers, which are only 13% of which are owned by the government. The others are contracted with the Ministry of Public Health, and they are owned by NGOs. So for us, when we say the public sector, it means the NGOs that are supported by the Ministry of Public Health. Within the API program, we support 800 dispensaries and 207 primary health care centers with vaccination. These centers provide free vaccination for children under 18 residing in Lebanon, regardless of their nationality. For the private sector, what we consider as the private sector are the private clinics that are run by pediatricians, sometimes in the outpatient departments of hospitals or privately owned clinics. Just to give you a notion about the structure of the EPI program in Lebanon, it is centralized at the Ministry of Public Health and the Primary Healthcare Department, which myself and my colleagues represent today. At the Primary Healthcare Department, we have primary healthcare coordinators in every district of the country. We have the EPI program manager and coordinator at the central level. At the level of the districts, we have 26 qada's. In the qada, we have the qada physician and his team who follow up on the dispensaries and the primary healthcare centers. As you see in this slide, we also follow up with orphanages, nurseries, schools, and dispensaries on the vaccination status of children enrolled in those schools, regardless of their nationality. Just to give you an idea about the coverage with the health outlets, this is the public sector. meaning the dispensaries and PHCs that belong to NGOs or municipalities, how they cover all over the Lebanese territory. And this is just to give you the idea about the distribution of the Syrian refugees and the vulnerable Lebanese. So if you look at both maps, you see that the coverage with the healthcare centers covers all the areas where the vulnerable Lebanese or the refugees are situated. In addition to the private clinics, as I said, that are not shown on these maps. This is the National Vaccination Calendar. It covers 10 diseases. We're planning to add the hepatitis and the Rota vaccine soon to the national calendar. As you see, PCV 13 is number 10 on the chart. It was added in 2016. So all these vaccines are provided to every child under the age of 18 residing in Lebanon. The vaccination calendar is unified between the public and the private sector. The private sector have additional vaccines which are the optional vaccines, like for example, they have hepatitis A and Rota, which we are planning to add to the national calendar in the coming years. So the role of the private sector in vaccination in Lebanon, as we said, that the non-profit NGOs who are supported by the Ministry of Public Health provide WHO pre-qualified vaccines, which are provided for free to the centers by the Ministry of Public Health, and it's mandatory that the center provides the vaccination service for free to the beneficiary. These are given through the primary healthcare network, which covers 207 centers and 800 dispensaries. The private pediatricians, of course, provide their service for fee, and they get their vaccines from private pharmaceutical companies. The Lebanese government, with the support of UNICEF, also has provided vaccination at the border sites and UNHCR registration sites. These are also vaccines that are provided by the ministry and supported by UNICEF. The role of the private sector in the vaccination, of course, they contribute to the coverage. They raise the coverage with vaccination in Lebanon. The only two vaccines that were provided by the ministry for the private sector were the OPV and the MMR, or even the measles monovalent vaccine, were provided through the Qada physicians to the private physicians who were willing to provide the service for free for the beneficiaries at their clinic. Here the pediatricians had to report on the number of children that were given these doses, and it has been clearly communicated that these vaccines are to be given for free. So only in this case, we had reporting from the private sector on the number of children which were vaccinated in the private clinics. The estimated coverage by the private sector in Lebanon is between 27% and 45% of vaccines are given in the private sector, and it depends a lot on the socioeconomic status of the area that we're talking about. For example, we have Kisirwain, Qada Kisirwain, which is a bit northern of Beirut. For those who know Lebanon, it's around Jouni area. And it's an area known for its high socioeconomic status. So 73% of vaccines administered in that area were administered by the private sector. Whereas Bint Jbeil, which is an area in the south of Lebanon with lower socioeconomic status, only 29% of the vaccines administered were given at the private sector. So in general, overall in Lebanon, the public sector, through PHCs and dispensaries covers around 55 or delivers around 55% of the vaccines. As I said, the reporting from the private sector is a challenge because they receive their vaccination they purchase the vaccination from pharmaceutical companies. So they do not feel that they are in any way obliged to report to the EPI program or the Ministry of Health. Then again, we are having the reporting on those vaccines that the ministry provides to the private sector. The estimation that we make on the amount of vaccines administered is through reports from the pharmaceutical companies themselves. They tell us the number of vaccines that were distributed to the private sector. About the quality issues, like Margaret mentioned in her presentation, we have issues with quality in the private sector because there is no monitoring neither on the way that the vaccines are administered, nor on the cold chain. Where in the public sector, of course, we have very tight monitoring on the cold chain and the ways that the vaccines are administered. Training for the private sector is very limited, and whereas for the public sector we do a lot of trainings for the healthcare providers on how to administer vaccines, how to do the reporting, so that we can have reliable data. In the adverse effects following immunization, there is very limited reporting from the private sector. In vaccine preventable disease surveillance, there is limited compliance. I will give the example of AFP reporting. For example, private hospitals do report on AFP cases to the ESU unit at the Ministry of Public Health. Also, if any private clinic or physician sees or diagnoses any communicable disease, they have to report to the Qada physicians at their Qada, who subsequently reports to the ESU department at the Ministry of Public Health. The vaccine schedule, as I said, is harmonized because the mandatory vaccines are common between the public and the private sector, but the private sector provides other optional vaccines that can be administered to the children. The involvement of the private sector is through technical committees. The EPI program manager involves the private sector in the technical committees. They are on board on all the campaigns that we do. The polio certification committee is uniquely chaired by the private sector. In the trainings, as we said, they are mostly focused on the public sector, the primary healthcare centers and dispensaries. For the committees and working groups, we have the National Certification Committee, which involves and depends greatly on the private sector for technical expertise. And we have, of course, close collaboration with the syndicates of physicians and the Association of Pediatricians. For us, the strength in involving the private sector is, of course, the coverage. You're increasing the coverage for children. They complement the mandatory calendar with the optional vaccines, and they provide technical support. The challenges, of course, reporting is a big challenge, and quality control of service provision and cold chain is also a challenge. For the future plans, of course, keep on with the collaboration between the public and private sector. It is planned to start having unique identifier numbers for children, at least starting at the primary healthcare center network, which are to be linked through a health information system, which is the Phoenix, which is currently piloted in 75 primary healthcare centers. And on the long term, to include all the dispensaries and the private physicians who provide vaccination. And of course, inclusion of hepatitis A and Rota in the national calendar. Also to help us identify the coverage that is provided by the private sector, we are currently analyzing the data of a sero survey performed in collaboration with WHO and CDC. And one of the questions that were asked in the survey was, where did the beneficiaries receive their vaccination? So we hope that will shed more light on the size of the contribution of the private sector in vaccination. Thank you.